Good morning, everyone. Welcome to our COVID-19 incident update for December 9th. I'm Carrie Schurig. I'm the Public Information Officer for the Shasta County Health and Human Services Agency. We'll start with our numbers. We've had a total of 6,055 confirmed cases, including 99 from Sunday and 132 from Monday. We have done 90,710 negative tests for a total of 96,765 total tests. We've got 46 people hospitalized, including 13 in the intensive care unit. We have an approximately 580 people in isolation. Those are people who are tested positive and are still contagious. And we've replaced our quarantine number on our daily updates with the available ICU capacity for two reasons. The first reason is that we are no longer able to track the number of people on quarantine because the number is too high. We can't do case investigation on every patient like we used to. And the available ICU capacity, as I'm sure many of you know, has suddenly become a very important number shared with us by the state on a daily basis, because that is what determines whether we go into a regional stay-at-home order. Right now, we are at 25%, and if we go below 15%, then we would be subject to that order. We have had 5,375 people released from isolation to date, and we have had 54 people who have died. With us today, we have Robin Schurig, the director of the Shasta County Health and Human Services Agency's Public Health Branch, and Dr. Karen Ramstrom, who is our health officer. We also have Robert Folden from Mercy Medical Center Reading and Mark Mitchelson from Shasta Regional Medical Center. Who would like to get us started today?
I can start. This is Robin. So I have a few pieces of information that I would like to share, starting with, as Carrie mentioned, the regional stay-at-home order that was announced by the governor last week. We are not impacted by it yet, but it could go into effect at any point that our ICU capacity dips below that 15% marker. And so again, this is out of all of the adult ICU beds available in our Northern California region. Out of all of the ICU beds that exist in our Northern California region, what percentage of them are available to receive patients at any given time? So that data is updated daily. The hospitals report it directly to the California Hospital Association, who shares it with the state. And that's what the state is using to determine whether a region will go into the stay-at-home order or not. So as I mentioned, our region is not there yet, but if that were to go into effect in our region, what it would mean is essentially the same thing as back in March when we had a stay-at-home order. People would be asked to stay at home as much as possible and only go out for essential purposes. So if you work in an essential job, you would be able to go to work. Schools would remain open. You would be able to go out for groceries or to pick up takeout from a restaurant, things like that. You'd be able to seek medical care still, of course. All private gatherings would be prohibited. So of any size, you would not be allowed to get together with even one or two other households. All non-critical infrastructure sectors would be closed except for retail. Grocery stores would have to keep a 35% capacity, and all other retail would have to reduce their capacity to 20%. So those are kind of the main points of what would happen if we were to enter into that stay-at-home order. It would be in effect for at least 3 weeks, and then we would not be able to come back out of it until, as a region, the state projected that our ICU capacity would be above that 15% mark. And then at that point in time, we would be assigned back to one of the tiers in the Blueprint for a Safer Economy tier system, based on whatever tier our data at that point in time qualified us for. In the meantime, since that stay-at-home order has not impacted us yet here in the North State, we are in Shasta County still assigned to the purple tier. So just as a reminder, that means that bars that do not serve food are supposed to be closed altogether. Bars that do serve food, along with restaurants and wineries, are supposed to be operating outdoors only. The same is true for places of worship, movie theaters, some other sectors. Hair salons and other personal care services are still allowed to be open in the purple tier, and that's one example of a tier that would, of a sector that would have to close if we were to go into the stay-at-home order. So they are allowed to be open now, they would not be allowed to be open under the stay-at-home order. So that is a good motivator for us to all stay vigilant and, stay at home as much as possible now, really. But when we do go out, make sure to keep your distance from other people and wear your mask and all of those things. The other thing I just wanted to mention briefly is that tomorrow the state will be announcing the launch of an electronic notification system called CA Notify, CA for California. It's a system that works with cell phones, and they have been piloting it at various university campuses, and they are now rolling it out statewide. It is completely voluntary, so people would be able to opt into it if they choose to. And the way that it works is it uses Bluetooth technology to track what other cell phones your cell phone is within 6 feet of for 15 minutes or more. Excuse me, so that if you test positive for COVID and you opt in to use this notification system, it would send a notification to other people who had also opted in and who had been within 6 feet of you for 15 minutes or more. They would have to opt in as well. So again, it's completely voluntary, and it would not release any personal or identifying information. It just says that you have been exposed to someone. It doesn't tell you who the person was or where you may have been exposed. So that will be coming out tomorrow. And that's all that I had to share, but I think Karen has some information she wants to share as well.
Good morning, everybody. So I just wanted to briefly share, and happy to answer questions as well. A lot of preparations happening around the COVID-19 vaccination and movement at the national level as well in terms of the vaccines that are available or going to be available soon. So the Pfizer vaccine is being reviewed by the FDA's advisory committee tomorrow to make recommendations to the FDA, whether they recommend EUA authorization. The FDA actually released yesterday their independent review and reanalysis of that clinical trial data and found promising findings. They confirmed the efficacy and safety findings that Pfizer had previously released, which were very, very reassuring. In addition to the FDA in California, the Scientific Safety Review Work Group will be reviewing that data this weekend. And I believe the Advisory Committee on Immunization Practices at the national level will be looking at that and making recommendations about use of that vaccine. And so all of that's very, very promising. And we'll see what the FDA decides. In the interim, there have been efforts to pre-position vaccines so that we'll be ready to use it soon after that FDA approval comes through, assuming that it does. And so we are set in our county to start receiving vaccine next week. Almost 2,000 doses for our county to use. And in addition, Mercy Medical Center Reading has been gracious enough to be a storage location for regional distribution to surrounding counties that are not able to take the minimum of 975 doses. And so we'll be working closely with them around that project. In addition, we just learned today that the Moderna vaccine, which is a similar type of vaccine as Pfizer, they also are interested in pre-positioning vaccine to be ready for use pending their FDA review as well. And so that may be coming as early as the week of the 21st. And so a lot of movement, and we're working, planning to actually meet this Friday with our healthcare partners to talk about initial dissemination and distribution of the vaccine that we anticipate to receive next week, and how that will be distributed across our healthcare partners who are in the early phases of this vaccine distribution. So happy to answer questions as well.
Sorry. Robert or Mark, do you have anything you want to start with, or should we go to media questions?
I think the only thing I'll add, we talked last week about ICU capacity, and I know that's become one of the key elements here. And I just want to reiterate that, in Northern California, we're fortunate that we have maybe per population more ICU beds than some other places in the country, number one. But number two, because of the fact that we're a regional trauma center and both Shasta Regional and Mercy help support a very large geography, about 30,000 square miles. You know, our ICU here at Mercy Reading is often, I'll say, close to capacity. So the one challenge with the tool, and now that we're going to regional ICU bed availability, one of the challenges in that state tool is there isn't a good way to enter our ICU surge capacity. And if I could have one magic wish, it would be to have that added to the document at the state level so that our leaders would have a better understanding of what our plans are and what the actual surge capabilities are. Because I know many of us have plans to surge our ICUs beyond the traditional walls that we report on a regular basis. So for the community standpoint, I want the community to know that when we say we're prepared, we're prepared beyond just what's reported. And the definitions in that report are very specific, and our Roadmap to Recovery Committee spent a fair amount of time talking about that tool. So I just want, you know, the public to know that we have additional resources available to us. And then we did meet with Region 3 EMS again over the weekend, and we bolstered our plans. So again, the way the agencies are working together right now is commendable.
All right, thank you, Robert. That's super helpful. Anything else before we open to media questions? All right, we are ready for media questions. If you are caller number 1, I'm sorry, I don't know who you are, but we're getting some feedback from your phone. So if you want to just let me know in the chat, or after we take a few questions, I can just open up your line for you to ask questions. Who has questions for us?
Oh, I've got at least one. For Robert and maybe Mark as well. You were talking about ICU capacity. How hard is it to expand an ICU? Like we were talking last week about, you could, at Mercy, you could open up the auditorium if you need for more beds, but how realistic is it to expand an ICU? I would assume that's pretty specialized.
So yes, a great question, Mike. Here at Mercy Reading, we have 10 additional ICU beds that are on our license, but we currently have what's called a flex waiver, and we use them for a lower acuity. So we use them for telemetry beds today. So our first thing would be to reactivate those 10 beds, which means we have to relocate the patients that are in that area today to a different part of the hospital. So when we spoke about leveraging other non-traditional parts of the hospital, those would only be for patients that are, you know, the lowest of acuity. Maybe they are getting ready for discharge. You know, they don't require the intensive resources that a telemetry patient or certainly an ICU patient would require. And, you know, all of us have capacities to then go outside of our ICU walls. But as I mentioned, we don't like to do that because ICUs are such a well-controlled environment. And we like to keep our, you know, our highly trained nurses, our highly trained physicians, our respiratory techs, we like to keep them with those patients in one area.
Thanks, Robert. What's the conditions at Shasta Regional, Mark?
So very similar. You know, we are running tight. It is definitely a little fuller than what we're typically at, but we're doing okay. We have some empty beds for availability, but similar to Mercy, we have a unit that's already pre-designed that we can easily flip into being another 12-bed ICU. So it would just be taking set population, putting them over to a lower level of care, and then making sure that we have the appropriate staffing mix and skill mix of our nursing staff and our doctors to man that extra space. So we could do it, you know, within a couple hours if we saw a massive surge. But really, at this point, we're looking at efficiencies within our current ICU and our med-surg areas, making sure that we have a good flow, getting patients discharged home timely, just so we don't have to go into those contingency plans.
Thanks, Mark. I've got a question for the county, and I don't know whom, but how are things at the Garden of Lights? Do we kind of have that under control now as far as the social distancing and masking and all that stuff? Has anything been done there to kind of alleviate what some people were saying was a problem?
Yeah, so we have been working closely with them, and they have made some improvements, and they're continuing to make improvements. We are also going to go out and do an in-person visit so that we can just make any further recommendations that we feel are needed, and they have assured us that they are more than happy to, do whatever we recommend in order to make it a safe environment.
Thanks, Robin.
Good morning, everyone. It's Anna here from Channel 12. Just wanted to piggyback back to the ICU. So I know Mercy has said in the past they can convert more rooms like to negative pressure rooms. Are those really comparable to ICU beds? Like, would it be the same?
Please don't mix those two topics. So an ICU bed is very different from negative pressure. So in the context of this question, and ICU beds are usually a highly specialized designated area within the hospital that has specially trained staff, and there is a square footage requirement of that room. Then there's the topic of negative pressure. So negative pressure is just an environmental control. So we can do that. We're fortunate that the way our hospital is built and the way our air systems work, that we can create a negative pressure environment on almost any area of our hospital. Not all of them, but almost all of them. So two different topics.
And kind of just to follow up on that then, Robert, does the state take those negative pressure rooms into account when it talks about ICU beds? I know you said they're two separate topics, but is it something they take into consideration?
No, it is two different topics. Depending upon which tool we're talking about, yes, they like to know how many negative pressure rooms we have built, but then there are how many rooms we can convert. So again, they're two very different topics. So in the tool that we're referring to here today, where we report daily on our staffing and ICU beds available and how many are staffed, I don't believe we're reporting how many negative pressure rooms we have. There is an expectation when we're dealing with any respiratory isolation that those patients are in the appropriate environment.
Okay, thank you. Also, does the state consider ventilators essential for each ICU bed? Maybe Robert or Mark could answer that for me.
At this point, they track it and how many were in use at any given time, but it doesn't coincide with COVID versus ventilators. Very similar. We have people that don't have COVID that are on ventilators, and we report everything, but they're in different buckets.
I do have something. Sorry, I had something I want to follow up on too. This one was again for Mark. I know I saw something that it said Shasta Regional is asking people who tested positive to take part in a study. Do you know anything about that? Can you just elaborate on this study that's happening this week?
I'd have to get back to you on that one. I'm not 100% sure what you're talking about.
It was I believe it was something like a Stanford-sponsored study for people who tested positive to come up to do some sort of testing regarding COVID.
No. That is something that is actually being orchestrated with one physician group, and I'm happy to give you some information offline to that. It's nothing that's being officially done within the hospital.
Okay. touch base. Thank you.
Also, I unmuted you, caller one, if you have any. Sorry, go ahead, Matt.
Hey, this is Matt Brandon for the record. ICU availability was 25% in its last update. How many beds is that out of? Because it'd just be helpful to know whether there are, if that's based on us having, 50 ICU beds in our region or 500. And how much could it be expanded to if the hospitals do expand their capacity?
I don't have those numbers in front of me. Karen, do you know?
I do. I did a little math yesterday. This is based on the California Hospital Association, what's in their data system for licensed beds. But with the caveat, as Robert said, hospitals may be using those differently, but the number of licensed beds across the region, across Shasta County is 86. And then I have to do a little bit more math. Hold on to get you the whole region. So if you want to ask another question, I'll get my calculator out just a minute.
Matt, I think this is part of the problem, is that historically we've operated as a county, the resources across the county, and now the state has sort of moved to this regional, which is it 11 counties or 13 counties? Carrie, anyway, the numbers have changed.
Yeah, it's 10 counties and 167 licensed ICU beds across those counties.
Okay. So, just can you put into context for people what the ICU availability is right now versus what it would be, in 2019 or 2018 before COVID?
Well, so I'll speak to Mercy Redding. So the irony is, of our 33 ICU beds, we almost always run a capacity somewhere between 27 to 30. There could be days where we have 32 beds filled, and it really came down to what's the demand within the community. Are we in what's referred to as trauma season? There are times of the year where we see more accidents that take place. So for us, it's not uncommon to have many of our ICU beds occupied. The difference with COVID right now is that we've sort of dedicated some rooms to COVID positive patients needing an ICU level of care. So that's really, for us, that's the bigger challenge.
Gotcha. And just to one more thing in that topic, is it also adding to, I guess, the pressure on Shasta County hospitals that a lot of the counties in our region don't have their own ICU capacity and have to send their residents to places like Shasta County?
Honestly, I think that it's very similar to what we see anyway, because our two hospitals are the receiving hospitals for all of the critical access hospitals in the North State, between Fairchild, Mayors, Trinity. They don't have their own ICUs anyway, so anything that would have needed that level of care anyway would come down to us. So really, it's just the same process that we've had in place for all this other transport.
So Matt, one of the whispers in my ear has said that the counties are Del Norte, Glenn, Humboldt, Lake, Lassen, Mendocino, Modoc, Shasta, Siskiyou, Tehama, and Trinity. So those are the 10 in addition to Shasta County.
Yeah, thank you for that, Carrie. I forgot I left Modoc out. Thanks.
Yeah, and then I'll add the only other thing that has sort of become a critical resource is having the ability to have a large oxygen supply. So if you're a smaller facility that doesn't have a liquid oxygen tank, a patient with COVID that requires a lot of oxygen, that makes it very difficult to treat those patients. So that might be one very specific population that needs to come to Reading that otherwise a hospital could likely care for them in their community.
All right, other questions?
Okay.
Yeah, go ahead, Matt.
I also wanted to, oh, go ahead. Oh, all right, I'll go. Thought I heard somebody. But for the vaccine, Dr. Ramstrom mentioned that we'll be getting some doses next week. Can you tell us how they'll be distributing them? Are they all going to be given out on one day? Will people be given them at work for healthcare workers, or do you drive up and get them, or how will this distribution for the vaccine work?
Right. So at the national level and at the state level in California, there's been a lot of work to determine prioritization frameworks for this initial limited supply. And so that's what we will be applying for this initial distribution that's coming in December. And so the vaccine work group, or advisory committee at the state level has determined what that looks like. And it's based on, informed by national frameworks as well, but they've determined 2 priority populations to start with, including healthcare workers and congregate settings, the workers and residents. And so even with that prioritization, we don't have enough in these initial supplies to vaccinate everybody. And so there's some additional prioritization criteria based on facility type that we will be applying. And we'll be doing that in coordination with our healthcare facilities and talking through how do we want to do that as a community to distribute those initial limited supplies.
When you say that I think you had said that we'll expect to get around 2,000 doses in our county next week. Do we know what day that would be, and would we be able to be distributing it, or will we have to wait a little longer? Do we know how long we'd have to wait?
Right. So we're getting the Pfizer vaccine. It comes in boxes of 9. Right. So we're getting 2 boxes for our county of Pfizer vaccine. Each of them have 975 doses, and it's anticipated to come around the 15th. But again, we have to wait for FDA authorization to use that vaccine, as well as review by the California Scientific and Safety Review Work Group, which is anticipated to be completed this weekend. And so, but we cannot distribute and utilize a vaccine until it's FDA authorized.
Gotcha. And do we have an idea of when that might be?
So as I shared earlier, so the data has been reviewed by the FDA. That information came out yesterday. Their advisory committee is meeting tomorrow. And then the advisory committee on immunization practices is meeting this weekend, as well as the California Scientific Safety Review Work Group. And so all of that's in the works right now. And so we may know more after the FDA meeting tomorrow. So we're all kind of asking the same question. And so keeping an eye on all of those key approval agencies meeting and making their recommendations and final decisions.
Cool. Thank you.
Other questions?
Well, while Dr. Ramstrom was there, I just read this morning that I guess there's been at least a small percentage of like allergic reactions to the vaccines in the UK where they've started injecting people. Is there any concern about that? Are you aware of that? Any comments about that?
So that's not surprising. Anytime we administer medications, it's not unusual for some percentage to have allergic reactions. It'll be interesting to see when the Pfizer clinical trial data is released, so we can see among that population, I think it was almost 50,000 people or so, what the allergic reaction rate was. And so hopefully we'll have more information after the FDA meets tomorrow, more granular information about what that looks like So, you know, more to come on that, but not surprising that there was some allergic reactions.
Thank you.
Hi, Anna here. Sorry, I just wanted to reiterate something, or probably I missed it. Dr. Ramstrom, did you mention how many ICU beds we had countywide?
Yeah, just from the quick review I did of the California Hospital Association information on licensed beds for the facilities in Shasta County, I counted up 86. So that's just based on what the California Hospital Association has on hand for licensed ICU beds. But remember, you know, some hospitals may be using those in different ways, as Robert has shared previously, how they distribute those number of licensed beds.
Thank you. And then, sorry, can I just get the number of beds again from both Mercy Medical and Shasta Regional?
You're talking ICU beds or total?
ICU beds, please.
We've got 22, and we expand to like 12 more than that.
Sorry, could you repeat that again, Mark? You cut off. So it's 22?
Yeah, and then we can expand to more than that.
And then Reading, we have 33, and then we have 10 more on our license that we can expand into, but we report 33.
Thank you.
Any other questions? All right. Does anybody else have anything to add that has come up? Okay. Thank you, everyone, for your time today. We appreciate you all being here, and we will see you again next week at 11 a.m. on Wednesday. Have a safe and healthy week, everyone.